Start the slideshow. There we go. So as we all kind of know, the country went on lockdown because of the coronavirus pandemic. And in Arizona, that took place on March 31st. But we were a little bit ahead of the curve in starting to think about the impact of the COVID pandemic on how we're going to provide care. So we tried to get together and start thinking about different things that we could do. We wanted to try and take advantage of some of the facilities that we have at Pima Heart and Vascular. Our heart center over here is on 2404 East River Road, and on the second floor, we have what's known as an office-based angio lab. So it's at the Pima Vascular office, and that is a place where we can do certain angiographic procedures. And it's been in existence for 6 years, has a long track record of safety and efficacy. So that was one option to be able to provide care outside of the hospital environment. And the other option on Orange Grove is our Pima Heart Surgery Center. Again, another venue where we could provide essential care and keep patients out of the hospital environment. Just to kind of give everyone the scope of the Pima Heart and Vascular practice, we really cover all of Southern Arizona. We have services available at all the major hospitals: TMC, Northwest, Oro Valley, St. Mary's, Green Valley, St. Joe's, and some services at Holy Cross. So in addition to what I'm going to talk about with this presentation, we're still providing care to hospitalized patients. Just to kind of review the scope of what vascular surgeons do and what the types of problems that we take care of, because that'll put it into context of what cases we thought were appropriate to be done and those that could be put on hold because of everything going on with the pandemic. So we take care of peripheral arterial disease, and that could be something that's more of a lifestyle problem like claudication, or more frequently, we're dealing with patients who are in jeopardy of losing their limb from critical limb ischemia. We take care of aortic diseases, aneurysms of the thoracic and abdominal aorta. And again, some of these presentations are acute, such as an acute aortic dissection. Some of them involve aortoiliac occlusive disease, again, where patients are in jeopardy of losing their limb from occlusive disease and poor perfusion. But many of these aortic conditions are more elective in that they can wait without harm to the patient. And same thing with cerebral vascular disease. We take care of carotid, vertebral, and subclavian artery disease that can lead to strokes and other neurologic events. And some of these are urgent and need to be dealt with acutely, while others can be handled on a more elective basis. Venous thromboembolic disease, the majority of these patients are hospitalized with either pulmonary embolism and or deep vein thrombosis. Venous reflux disease, on the other hand, is when there's valvular dysfunction in the superficial venous system causing insufficiency, varicose veins, venous ulcers, deep venous obstruction. Upper extremity disease largely revolves around thoracic outlet syndromes, and these can affect the arteries, the veins, the nerves, or combinations. Vascular access, the creation of arteriovenous fistulas and grafts for hemodialysis, maintaining hemodialysis, arteriovenous fistulas and grafts, placements of portacasts for chemotherapy, and placement of catheters for hemodialysis and plasmapheresis. And then lower extremity wound care, which ranges from diabetic ulcers, venous ulcers, ischemic ulcers, combinations of these pathophysiologies. And then, of course, with our hospitalized patients in Southern Arizona, it's not uncommon for us to be doing minor or major amputations. So on March 20th, we had a group meeting amongst the vascular surgeons, along with, in the context of the whole group, and we made the decision to stop doing elective cases. We would use the office-based lab for the management of critical limb ischemia and dialysis access maintenance, and the ambulatory surgery center for dialysis access creation, maintenance, and placement of ports for chemotherapy. And our hospital cases would be limited to inpatients and urgent or emergent cases. So one of the challenges with this pandemic is the definition of elective surgery. And there's a lot of different thoughts on that. Some people define elective surgery based on timing. And if you're the charge nurse at the OR desk at any hospital, elective is anything that doesn't need to be done immediately. Some people define elective based on the urgency. An elective surgery can be scheduled at someone's convenience. It's not going to, delaying the surgery is not going to critically impact the patient's outcome, versus urgent and emergent surgery needs to be done fairly quickly to avoid a bad outcome for the patient. And there's even some definitions of elective based on payers, where payers define elective as procedures that are really not absolutely required for the patient's health and well-being. Again, lots of lack of agreement on the real definition of elective. This is some slides. This one the one on the right is from a perioperative nursing presentation, where elective surgery was defined as being performed when surgical intervention is the preferred treatment for a condition that is not imminently life-threatening or to improve the client's life. On the left, this definition was it's pre-planned and based on the patient's choice, availability of scheduling for the patient, surgeon, and the facility. Delay of surgery has no ill effects. This is a paper that was recently published in the Journal of the American College of Surgeons, and this was a group of surgeons from the University of Chicago who tried to come up with, in the context of the pandemic, a scoring system in an effort to try and ethically and efficiently manage our resources. And it's a fairly complex system, but again, it's one of many attempts to try and help guide the use of our resources in the context of the pandemic. This system looks at 21 different factors regarding the surgery. So this first table lists procedural factors: the OR time, estimated length of stay, use of the ICU, blood loss, size of the surgical team, likelihood of intubation, and surgical site. And each one of these factors is given a score of 1 to 5. The second table is disease factors. Non-operative treatment is non-operative treatment option effectiveness, non-operative treatment option resource and exposure risk, impact of a 2-week delay on the disease, impact of a 2-week delay on the surgical difficulty, impact of a 6-week delay in disease outcome, impact of a 6-week delay in surgical difficulty and risk. And again, these are each given a score of 1 to 5. And then finally, we have patient factors: age, presence of COPD, obstructive sleep apnea, cardiovascular disease, diabetes, whether the patient's immunocompromised, symptoms, exposure to COVID. And this would result in a score called the MEN-NTS score, which is the medically necessary time-sensitive score. And if you had a low score for the procedure in the patient, it was okay to proceed. If you had a high score, it was better to hold off. But again, there's a large gap in the middle of patients that really require judgment. And I think that's becoming, to me, the key of most of our decision-making when it comes to the pandemic is some judgment and common sense. This is the table that was put out by the American College of Surgeons in concert with CMS, where procedures were placed into tiers: Tier 1, Tier 2, Tier 3. Tier 3 are sick patients in the hospital with high acuity that need to be taken care of. Tier 1s are the lower acuity patients that probably could have their surgery delay. And again, Tier 2 are more urgent patients that require some level of judgment. So in response to this challenge, we developed somewhat of a protocol, again, trying to take advantage of the venues that we had available within our practice to get patients taken care of. And our goals were to try and minimize the touch points for patients and staff. By doing that, you minimize PPE consumption, take care of essential care, meaning delaying the care would impact the patient significantly, and then constantly reassess our strategy for safety and effectiveness with biweekly meetings. And a perfect example of where there's controversy is if we look at a patient who's on hemodialysis with a catheter. There was recently a journal, the Endovascular Today journal, where this was discussed, and the surgeon said they're not doing any dialysis access creation at this point in time. Well, I don't agree with that approach, and here's why. If a patient initiates dialysis with a catheter, the longer the catheter is in place, the higher the risk is for that patient for sepsis and mortality. So where I don't see creating an AV fistula graft as an emergency, in the context of a patient, it's more of an urgency. And if that can be done outside the hospital setting, then I think it's in the patient's best interest to do that if we can minimize their risk. So if we just look at touch points, if a patient comes into the hospital for outpatient surgery, there's 11 possible touch points for that patient where they're going to interact with staff. The valet, the people screening you as you walk into the lobby, the admitting staff, a preoperative nurse, the anesthesia provider, the circulating nurse, the scrub tech, the surgeon, the assistant, the post-anesthesia care staff, and the discharge staff. So 11 different interactions for that patient with hospital staff, and each one of those interactions requires PPE. If we look at our surgery center, on the other hand, we have 6 touch points for the patient. The preoperative nurse, the circulating nurse, the scrub tech, the surgeon, the anesthesia provider, and the post-anesthesia care staff. And then if we look at our office-based lab, we can reduce the touch points to 4. We have a pre- and post-operative care nurse, a circulating nurse, a scrub tech, and the surgeon. So we went ahead and looked back at our experience. We looked at the 6 weeks before COVID for the types of cases we were doing and the percentage of those cases. And here you see in the 6 weeks before COVID, so that's prior to March 21st, this was our distribution of cases. These are hospital inpatient. This is our vein center. This is our OBL. This is our surgery center. And this is hospital outpatient. Then we looked at the subsequent 6 weeks within the COVID pandemic. You can see an increase in our hospital inpatient, not unexpectedly. The biggest decline was at our vein center. OBL case percentage went up, ASC went up, and hospital outpatient went up as well. If we look at the volume of our vascular cases over these 2 time periods, again, group 1 is the pre-COVID before March 21st. The orange is within COVID, the 6 weeks to follow. Not unexpectedly, a big decline in aortic surgery because most of those are elective, truly elective, that whereby delaying a patient a couple of weeks is probably not going to have much of an impact unless they have a gigantic aneurysm or a symptomatic aneurysm. Again, not unexpectedly, a huge decline in our vein center venous insufficiency cases, which are purely elective, but still doing amputations, symptomatic carotids, critical limb ischemia, and vascular access cases. If you look at our touch points, so this is just for outpatient care, hospital outpatient, surgery center, and OBL. In group 1, we had a total of 996 touch points for the patients. In group 2, assuming we have the ASC and the OBL, that's down to 588. But this is the more important number. If we did not have the OBL and the ASC available and we had to do all this outpatient care at the hospital, we would have a 34% increase in touch points for the patients. So to kind of summarize, COVID-19 has definitely created significant care delivery challenges for us. Inpatient vascular surgery for acute limb ischemia, hospitalized critical limb ischemia, amputations, symptomatic carotids, and large and symptomatic aortic aneurysms continue. And I think it's well known there's a certain relationship between active COVID infections and hypercoagulable states, which may result in either deep vein thrombosis, strokes, pulmonary emboli, or critical limb ischemia. We have certainly seen some of that, but not much. However, with the heart and vascular, with Pima Heart and Vascular's ASC and OBL venues, we've been able to provide essential outpatient care with fewer touch points for the patient, which ultimately translates into reduced exposure and reduced PPE consumption. I'll end it there, and we'll be happy to take any questions that have come up.
Hi, Scott.
Luis, yes, sir.
A great presentation. I want to ask you a question. I agree with everything you said. We live these changes every day. We're still living them through. Let me ask you, from your perspective, what has COVID brought to us positive? I mean, what are the changes? Let's say that as a miracle, this disaster disappears in a month. Let's say August 1st, COVID is gone from Earth. What would be the things that you have learned through this COVID experience that you will keep for the rest of your vascular care, for the rest of our lives as vascular surgeons?
Well, I'll tell you, probably the biggest one I didn't bring up because it didn't have to do with necessary procedures, and that's the ability to take care of patients remotely. I think, as we've discussed in many of our meetings, I think much of our follow-up care lends itself to telehealth. And I can only hope that the regulatory agencies agree and see the benefit to telehealth so that they make it worth our while, because the barriers to telehealth before COVID were not being able to get paid for the care that you were providing. And I think there certainly has been initiatives that I've read about at state level to increase funding for telehealth. And I think it's going to be an obvious conclusion that Medicare, which drives much of what the rest of the country does and payers do, is going to appreciate that there's a real role for telehealth in delivering routine care. It's more convenient for the patients, for sure. They don't have to drive to an appointment, which can be a challenge. They don't have to sit and wait for the doctor that's running an hour late. So I think there's an incredible benefit on both sides. But it has to, the infrastructure, I think, is going to obviously get better, because technology is one of the beneficiaries of this COVID epidemic, or the pandemic is driving technology. And I think ultimately we're going to benefit from that standpoint. Now, is that going to also translate into a lot of the other things that we do, like, for instance, learning experiences? Are we going to be able to do more remote learning rather than have to get on a plane to go to a meeting? Your meeting has had great success thus far with remote access. I think it was out of our comfort zone 3 months ago. I think we're all getting very comfortable with, being able to sit in our pajamas and go to a conference. So I think that's going to be a benefit. And then I think just for us, I think it really reinforces what we kind of already knew, that there's been a long documentation of provider and patient satisfaction, as well as economic benefits to having surgery centers and office-based environments. And I think this pandemic just really reinforces that, to be able to provide care away from the congested campuses of hospitals and minimize the interactions and the consumption of PPE. So I think I think everything's going to benefit ultimately, but we're going to have to get out of this trench that we're in to really appreciate it.
Thank you.
Anyone else have any questions? Well, great. I really appreciate those of you who took the time to attend. Any feedback will be greatly appreciated. And everybody have a great day. Mask up and stay safe.